Okay. Today we'll be talking about end-tidal CO2, also known as the proof of life gas. So, we'll be kind of going through some of its physiology, the waveforms, what it looks like on the monitor, and then we'll go through kind of a few scenarios and how the waveform may change, what makes end-tidal CO2 go up and down, and how we can use it to be. So this is coal. What is this?
Oh, a bird.
It's a bird. What type of bird? What bird do they put in a coal mine?
Canary.
A canary. So a canary in the coal mine, it can be sort of an early indicator of a lot of badness. So remember that. And it's something we have on all of our ventilated patients on the vent. So certainly useful in the ICU for monitoring. We can use it for sedation, as we give people medications like propofol or something that typically is a respiratory depressant. May cause some hypoventilation. You'll see your end-tidal CO2 go up. Obviously, we use it in intubation for ET2 confirmation, and then also ALS. And we'll kind of get into some of that and some goals we want to be hitting with our end-tidal CO2 for cardiopulmonary resuscitation. Okay, so we'll go through kind of the physiology of the body and why do we make CO2 and end-tidal CO2, and what is it. So, everybody see my diagram? We're good? So basically what we have is the blood gets oxygen in the lungs, correct? And then this is essentially like the aorta going to the rest of the body, and you have your PaO2. What does PaO2 stand for? Hey.
Yeah.
Yeah.
Partial pressure of oxygen.
Do we have any other RTs here right now? Okay. Yeah, get them over here. What are they doing? So yeah, PaO2, partial pressure of oxygen on the arterial side, PaO2. Okay? So that goes to this muscle and gets used by the muscle, and it goes through something we call, has anybody ever heard of the Krebs cycle? There's like a lot of cofactors and blah, blah, blah and stuff happening, but basically that's creating energy, and a byproduct of cellular metabolism in the Krebs cycle is what? Carbon dioxide and water. CO2. So this is the venous side of things. Now we've gone through the capillaries and the Krebs cycle and the muscle, or whatever other cell, and we have PVCO2, so we have venous CO2 essentially is what that stands for, and then we travel back to our lungs because we want to give off CO2 and then gain O2 back so the cycle can repeat, right? So when we get to our alveoli, we have P big A, P alveolar CO2, it gives off, and then it comes out of the airway all the way through our circuit and then gets to be end-tidal CO2. So end-tidal CO2 is basically a surrogate for our alveolar CO2. Now in this process, which one do you think's higher, and typically higher, end-tidal CO2 or PaCO2? Is there typically a discrepancy that's normal between those two?
About 5.
Yeah, about 5 to 10 millimeters of mercury. So if you think like going through this airway and all this tubing, there's like a bit of an air mixing and like dilutional factor to where your end-tidal CO2 is typically like 5 to 10 less than your PaCO2. That's normal. If you have diseased lungs, i.e. filled with fluid, pus, pneumonia, you have shunt or VQ mismatch physiology in the lungs, that gap is going to get greater. Does that make sense? And so that's where you'll see me not use end-tidal CO2 as much for like making vent changes per se, because I can't rely on it as much because our lungs are pretty diseased, and what my end-tidal CO2 may not reflect what my PaCO2 is or my PvCO2 is, which is affecting my pH in the blood. So that's when I'm going to have to rely more on like BVGs and AVGs to really see what is my pH and what is my PvCO2, right? Because this is part of the transport process of getting it out to reading it all the way over here, okay? So those are some things we'll get into over here with regards to what affects end-tidal CO2 going up and down and how can we use it. Okay. So is everybody's somewhat familiar with the end-tidal CO2 waveforms, the yellow things we see? Okay. So this is kind of a graph of what a normal waveform looks for end-tidal CO2. And you have phase 1, 2, 3, and 4. So phase 1, our end-tidal CO2 read is 0, but we're still exhaling. That is basically the clearance of the dead space that doesn't have any CO2 exchange in the lungs. So basically like the main airways. Those are not, they don't have alveoli attached to them, then they're not readily exchanging CO2. So initially when you breathe in, the first part of your breath out is basically that column of air is your airways, right? Does that make sense? So we clear that out and that stays 0. And then we start to get a little bit of a mixture of dead space and alveolar emptying so that end-tidal CO2 starts to rise, right? And that's our relatively brisk upstroke. Phase 2 is some dead space mixing now with alveolar PaCO2 and reading it, end-tidal CO2 here, and then that starts to plateau and then become all alveolar end-tidal CO2 at your max end-tidal CO2 up here. And in like a normal individual, it's typically around like 40-ish, right? Give or take, you said about 5, depending on what our PaCO2 is, or our PvCO2. And then all of it goes out, and we basically, then we start to inhale, quick drop, and then it levels out there again, and then the process starts over again. Does that all make sense? Okay. Now the body in its steady state, remember this equation, pH or the H plus content, the pH is equal to basically like your ratio of PCO2 to your bicarbonate. And the body always wants to keep that like in equilibrium, like 735 to 745. So there'll be certain instances where the body makes more CO2, or it can't clear its CO2 as well in the body, and we're going to increase our minute ventilation to breathe off more CO2. So tidal volume times respiratory rate is your minute ventilation to help clear off your CO2. So let's go through a few scenarios where your end-tidal CO2 might go up and your end-tidal CO2 might go down. And this is, now I said your body will adapt. If your CO2 starts going up, you're making more CO2, your body will adapt by increasing its respiratory rate and its tidal volume to try to get back to that baseline, right? But initially, your body doesn't do that, and you get changes, and you'll see those changes in end-tidal CO2. So this is saying if your minute ventilation like stays the same, and you see increases and decreases in your end-tidal CO2, this is what this could represent. Okay, so these are things that could be the what?
What part of it?
The canary in the cave? Yeah, canary in the coal mine, exactly. This could be your early indicator. Before everything else goes worse, you can see these early indicators potentially in your end-tidal CO2. Minute ventilation and end-tidal CO2 are inversely related. So this is like, just in general to say, like if your minute ventilation isn't staying stable and you decrease your minute ventilation, right? And you're still having the same amount of CO2 production, but you're not breathing it off, then each breath off is going to be more CO2, right? So if you're decreasing your minute ventilation, your end tidal CO2 should go up. And this is just another concept. If you increase your minute ventilation, your end tidal CO2 should do what? Go down. You're breathing it off. Okay. Everybody get that? Does that make sense? Okay. So again, say you have a stable minute ventilation, but you increase your metabolic activity. Say you're shivering, or does a fever increase your metabolic activity in this cycle? Yes. So what are you going to do? You're going to produce more what? Okay, so a sudden uptick might be seen in, I'm just going to say increase metabolism. So fever, shivering, hyperthermia in general. Sometimes you'll see this in like a code. If you're looking at the end tidal CO2, IV bicarbonate. Make it go up. Do you know why that is? The HCO3 essentially through the buffering system gets shifted to CO2. So yeah, if you have an extreme acidosis, bicarb will make things like transiently better, but you're going to produce more CO2 that just needs to be breathed off. So you have to pay for it on the back end. So unless you increase your minute ventilation, your respiratory rate, your tidal volume to breathe off that extra CO2 you made, you're just going to create more of an acidosis with the respiratory side of things. And then what's the other thing we use in like? Yeah. So what about in ALS and if we get ROS? Yeah. So typically you're going to see a sudden spike. And then tidal CO2 likely means you have turn of spontaneous circulation. And what do we want to use to say we have adequate chest compressions? We want to be greater than or equal to about 20 millimeters of mercury for good CPR. If we are less than or equal to about 10 millimeters of mercury for greater than or equal to 20 minutes, that's pretty correlated with futility. Like they're gonna die, they're not gonna survive. Or if they do, they're gonna end up like, unfortunately, a lot of our patients end up brain dead. And then really even like greater than 5 minutes is like poor outcomes. That's why everyone should really have end tidal CO2 as one of our metrics we're looking at in CPR and in our codes. Cool. All right. So this is another one. So that's kind of the increase in end tidal CO2, but the decrease in end tidal CO2. Basically, this will happen if we increase dead space ventilation. Okay. So can anyone think of certain scenarios that might happen?
Cancer?
What's up?
Emphysema?
Sure. So I think what we're kind of describing certain things. Air trapping, sure. So I'm just going to say bronchospasm. Okay. So or like mucus plug. Like, what if we were to just obstruct this, right? Your body's then going to breathe faster to try to access other areas to get rid of that CO2. But in the instance, if your minute ventilation is at least initially staying stable, you should have a relatively sudden drop in that. Yeah, because or bronchospasm, obstruction, plug, what have you. Okay, you should see a drop, and then again, the body's going to want to maintain this, and it's going to have CO2 to blow off. So you're going to see the patient get tachypnic, higher tidal volumes to try to then find other areas of the lung that it can exchange that CO2 and get that end tidal CO2 off. So if I had an obstruction here or bronchospasm, would my curve look like that?
No.
What would it look like? This is coming out relatively quickly because there's no obstruction.
Smaller?
So yeah, this is like a shark fin, the shark in the water. So it comes out kind of more gradual. You'll see if you open up that obstruction or you give someone a bronchodilator, that should return somewhat back to normal. Sometimes if you've got COPD and just kind of chronic obstruction, you won't see it ever get back to completely being normal. But that's a change in your waveform. So if you see shark fins, they probably got some sort of airway process going on. Obstruction, bronchospasm. Okay, so that's the airway. What do we call this? Pulmonary artery coming back to the lungs to exchange CO2, and then you had to get a big clot in there. What's that called? Yeah. PE. Not only are we not able to exchange CO2 as well, but we may also be putting strain on the heart and have reduced cardiac output. So you're not going to deliver as much end tidal. So you may have a couple different mechanisms that drop your end tidal CO2 in a PE. And really, if you have end tidal CO2 and you know pre-PE what your end tidal CO2s have been, and you don't have much else going on in the lungs, it has a pretty good negative predictive value for PE. Like, you should see an increase in dead space. You should see a drop in like end tidal CO2, and that discrepancy between your venous and your end tidal CO2 if you truly have had a PE. If you don't see that, then whatever's going on probably isn't from the PE. So it's got a good like negative predictive value. But you see a drop in PE. What about, so we block the airway, we got a PE here. What about if we like fill up the lung? Okay, so pulmonary edema, interstitial edema. What about a pneumonia or ARDS? Something like that, yeah? Okay. It's gonna drop our end tidal CO2 at least initially. And then if we have a big spike in end tidal CO2 with ROSC, what about a drop in end tidal CO2? Mean like what's going on with the heart?
Oh wait, no, that's a mistake. I'm sorry. Yes, you just did.
Means you got a drop in cardiac output, hypoperfusion. And you might have like a pending arrest, okay? Something's going on. So again, can be kind of like the canary in the coal mine in terms of identifying something that might be going on in these areas. Okay? So in PE, end tidal CO2 is good, and then boom, it's down. All right? Same thing, cardiac output, hypoperfusion, end tidal CO2, we're doing just fine, and then down, down. So that is kind of how end-tidal CO2 works and how you can use it in the ICU. And it's just another, it's like the, I don't even know, how many vital signs do you have? 5?
Yeah.
Heart rate, respiratory rate, blood pressure, SpO2, temperature. So it can be like the 6th vital sign, really, like in the ICU at least. And it can help you kind of figure out a little bit what's going on. Like, you know, you got a lot of dead space if you've got a big gap between your venous like CO2 and your end-tidal CO2. Something's going on here that's causing that exchange to not be less than or equal to about 5, right? Conversely, you'll hear me say, right, RTs, if I match my end-tidal CO2 within about 5 of my venous CO2 and I have good SATs, like, do I need a gas really to tell me, and they're setting their own respiratory rate? No. We know they're comfortable, we know they're hitting their equilibrium set point, setting their own, you know, pH that's going to be physiologically correct for them, and a physiologic minute ventilation that keeps their CO2 and end-tidal CO2 normal for them, and their state. So, yeah, I think I'll get away from that as much if we've got pretty significant pulmonary issues, or pulmonary disease that's going to make that discrepancy and that dead space ventilation much higher. Then I can't rely as much on that. But you can still rely on trends, right? Like if I see a sudden drop or a sudden increase and I'm tuned into that end-tidal CO2, I might be thinking of these certain things that could be going on. Cool? That's coal. Okay? That's a canary. Go to tweet tweet. Your end-tidal CO2 is dropping. They're about to arrest. Get the code, get the crash cart. Yeah, any questions, concerns? No? Alright. So yeah, I would, as like RTs, be aware of like their end-tidal CO2s, not just their gases, but their end-tidal CO2s and where they've been. Try to marry them with the gases that we do get and be like, is this someone we need to be getting gases on? Or can we just titrate things via our end-tidal CO2 and our PA or our O2 sats? Also, okay, patient's not doing as well. Where was the end-tidal CO2? What happened? Okay, and being dialed into that. Again, this is it has to be seen like in the moment somewhat, because the body's going to then adapt. They're going to get tachypnic. They're going to try to adapt and change that end-tidal CO2 back to what's normal for them, depending on what just happened. The mucus plug, the pneumonia, the PE, whatever, the heart issue, that reduced the hypoperfusion. And then nursing, also a good thing to just kind of notate, you know, in the stable state, what does their end-tidal CO2 look like? If it changes suddenly, make the doc aware and kind of think through, all right, what could be going on with the lungs? And then I'll try to talk a little bit more about end-tidal CO2 monitoring, talk about it a little bit more on rounds. If we do have a change, what does that mean and what's probably going on with the lungs? Maybe marry it with the chest x-ray or whatever else we see. Ultrasound, heart function, etc. Cool. Again, reiterating uses. So definitely ICU monitoring, conscious sedation, where you want to, you know, make sure you're not hypoventilating the person, because hypoventilation is the first thing, and then what's the second thing? So you hypoventilate, and then you kind of deoxygenate, and you get hypoxic as well. And I've seen that happen, and people die. Innovation, end-tidal CO2 for ET2 placement. So we've got this little I'll do this last little part. The capnogram, right? Our T's are, and it attaches to like the ET2. So you've got these little areas here, yeah? And what is it? There's A, there's B, and there's C. It's typically purple. And then in the presence of CO2 detection, that takes it to yellow, okay? And if only this area, A, turns yellow, this means you got a partial pressure about less than 4 millimeters of mercury of CO2, partial pressure. If B turns yellow, you've got about 4 to 15 millimeters of mercury, CO2. And if C turns yellow, you've got about 15 to 38 millimeters of mercury of CO2, okay? So you want to see this whole thing pretty much turn yellow. Do you guys know that?
I did not know about the pressure. That was
Okay, yeah. So, and then this thing will last, I think it's for about 10 minutes or so. So like in a code, I would just keep this thing on. If we intubate someone, it's a difficult intubation. You don't necessarily see it go past the cords. I mean, that's like never happened. I mean, intubate someone, but no, just kidding. It's definitely happened. You may get some CO2 from the stomach that will like falsely kind of register that you're in the airway. But over time, when you're bagging and you deplete that, it's not just like, oh, I see a little bit of color change, take it off. Just keep it on and make sure
it's actually
every breath is like it's yellow, yellow, yellow. So this can like not be hooked up to like a monitor or whatever, but basically is just in line and just keep it on. Does that make sense? To know that we're getting color change and we're getting consistent color change. It's not just going away and, oh, by the way, we might be in the esophagus. Because everything's wild in the code, and you know, you think you got the airway, but you may not. Cool. Good. All right. It's a wrap.